Good evening, everyone, and welcome to TZAN's webinar on oral corticosteroid stewardship for asthma in adults and adolescents. My name is Zala, and I will be your moderator for today's session. I would like to thank you all for joining us this evening, and thank you to our sponsor, Chiesi, for their support of this webinar. To begin, I would like to welcome our chair, Professor Vanessa McDonald, to the acknowledgement of country and run through the webinar's overview and housekeeping points.
Before I begin, I would like to pay our respects to traditional custodians on the lands on which we're all meeting actually today in this virtual space. So we're physically located across traditional lands of several nations and languages, including the Gamilargal tribe, in which the offices of the Thoracic Society of Australia and New Zealand are situated. I pay my respect to elders past and present for the future, for the memories that they hold and for the traditions and the cultivation of the lands, the sea and the communities in which they've fostered for many, many years. I also acknowledge and pay my respects to the iwi and the hapu people of Aotearoa, New Zealand, and the Tangata Whenua people on whose lands the TSANZ is situated in Aotearoa. So it's my very great privilege to host this webinar today in collaboration with the Thoracic Society of Australia and New Zealand, Asthma Australia, and the Centre of Excellence in Treatable Traits. My name, as Zala said, is Vanessa McDonald, and I lead the Centre of Excellence in Treatable Traits. And I've had the privilege of working with our presenters today and working with the Thoracic Society and Asthma Australia in terms of developing oral corticosteroid stewardship programs, and now looking at how we can implement these approaches into practice. So we've got some speakers today who will be presenting on oral corticostewardship with two different lenses. We've got Professor John Blakey from Curtin University and St Charles Gardner Hospital in Perth, and he will present an adult perspective. And then we have Dr Shivanthan Shanthikumar from Melbourne Children's Hospital, who will be presenting on a paediatric perspective. We'll then bring that together at the end and have a panel discussion where both John and Shiv will join us, and we'll also be joined by Desley Hegney, who is a person with lived experience of asthma and will provide a really important consumer-centred perspective on the use of oral corticosteroids in asthma. So we're in for a nice afternoon, I think. Oral corticosteroids has emerged as a really important, oral corticosteroid stewardship has emerged as a really important focus in asthma and airway disease in particular. A couple of years ago, with John at the helm, we published a Thoracic Society position paper on oral corticosteroid stewardship, and since that time have been really developing some initiatives and approaches toward achieving the goals of stewardship. We've also been in partnership with Asthma Australia, and on World Asthma Day on the 6th of May, we launched a new campaign in partnership with our peak consumer body, which looked at smarter oral corticosteroid use. So really highlighting the need to be very particular about when we use oral corticosteroids. This afternoon, you'll find out why that's really important and some of the approaches that we can think about in terms of optimizing our use of oral corticosteroids in people with asthma. So without further ado, I will introduce our first speaker, and that is Professor John Blakey. So as I said earlier, John is from Curtin University and St Charles Gardner Hospital in Perth. John has a clinical and research interest in asthma. He's a respiratory physician. He's also the advisor of Asthma Australia and Asthma WA. And he's been heavily involved in this area of optimizing oral corticosteroid use in asthma. John has a wealth of experience and a fantastic research track record in asthma in terms of clinical care, as well as like health service research. So he brings great knowledge and great expertise to the topic today. So I'll hand over to you, John.
Thank you very much, Vanessa. I hope you can see my slide there okay. Thank you very much for that kind introduction. I feel like I have to deliver on that now. And thank you also to the Thoracic Society and Asthma Australia and the CRA for asking me to present today. So over the next 25 minutes or so, we're going to be talking about the principles of oral corticosteroid stewardship. Now, this is something which is going to have more of a perspective from the adult side, because I'm an adult physician, and then Shiv can talk to us more about the pediatric aspects later. But I think the principles can be applied across both age groups as we think about how best to improve the care we're delivering moving forward. So those are my conflicts of interest. And just to clarify as well, that the views that I'm going to present are my own opinions, and I'm very happy to discuss those in the panel later on, and not necessarily those of the sponsor or the organisers. So the learning outcomes from this presentation are going to be to describe some of the benefits that we can see from oral corticosteroid use in asthma, to outline the potential harms of OCS use, and again, that will be covered in the second talk as well. Think about some of our overarching principles of OCS stewardship, and then think about some examples of the interventions that we can use to reduce OCS use from each stage of the journey a patient might go on, or a person with asthma might go on, I should say. So this is going to be an overview of the area. As Vanessa mentioned, we have a position paper out in respirology from the Thoracic Society of Australia and New Zealand. So if you're the sort of person who likes to read, that's a good place to go to get all the appropriate references. If you're the sort of person who gets your information more from the web, the Smarter Oral Steroid campaign that Vanessa mentioned has recently been launched, and some excellent web pages at Asthma Australia's webpage. And if you're the sort of person who gets your information from TikTok, I'm sure it won't only be a matter of time until Vanessa and Shiv have their TikTok dancers uploaded there for you to explain stewardship in a different way. On an important note, though, I think it's crucial to emphasize that we can't be flippant about the idea that people get a lot of their information from social media, and that clinicians are not as good as they should be about being out in that space, providing information in a form that people want. So something for all of us to work on, I think. So I'm going to spend a few minutes thinking about how we got to this point where we need oral corticosteroid stewardship. So I'm going to wind you back into the 1940s. And if you had asthma in the 1940s, that your treatments were pretty limited. You could get some adrenergic inhaled medications through devices that would approximate what we think of as a nebulizer now, and they were pretty widely available, particularly in hospitals. For over 100 years, people had been using asthma cigarettes. So they have kind of weak alkaloids, the forerunners of ipratropium or something like that inside them. And there had just been the launch of these things that would be the precursors of inhalers. So this is the Aerohaler from Abbott Labs, and there were drugs like norethisterone and things like that coming into these devices. So you could get some treatment, not desperately effective, and also with significant side effects. Moving up into the late 40s and into the 1950s, there was the discovery of more of our understanding, and then the discovery of the hormones from the adrenal gland. And shortly after these fellows were awarded a Nobel Prize for their discoveries, we started to see research papers coming out describing the use of steroids in asthma. So it's a typical kind of paper that you might have seen in the early 50s, this one from the New England Journal of Medicine, which describes individual symptom burdens, the cortisone or ACTH that they were given, and their response therein. So a huge amount of excitement over this new discovery, and that people were moving from the discovery into clinical practice very, very rapidly. So in 1955, the story has it by accident, there was the discovery of prednisolone, and the key aspect to this medication that was appealing was that it had about twice the half-life of cortisone. So you could just give it once a day. And so this drug we've had now for 70 years or so, and I think it's important for us just to have a little think about how different the world was 70 years ago in other ways. And we still had problems with things like bus segregation in America and people being executed in the UK, and it was a very, very different world that everybody lived in. And so it's really extraordinary that this medication has been so adhesive over the years. Sorry, I'm having a bit of problems with my computer. Okay. Now, not long after the discovery of this medication, there was an organized randomized controlled trial of its use in acute asthma. And again, I think that's a really extraordinary achievement. Just a year or two afterwards, groups of hospitals had got together to trial prednisolone in acute asthma. So these were individuals who come to the emergency department with asthma. They were not improving after 24 hours. They were failing on adrenaline, aminophylline, and oxygen, and they were randomized to receive prednisolone or not. If you took a representative 10 patients, to put it in the natural frequency terms, 2 of the patients would get better whatever you gave them. 2 of the patients would still be pretty sick on day 4, whatever they had been given. But 6 patients would have a differential improvement if they had been given steroids. And so for 6 out of 10 people improving on a medication, this was a huge jump upwards in efficacy from what people had seen before. Bearing in mind that 4 people still didn't have a benefit, but 6 out of 10 did, huge improvement. And so very quickly, this was adopted widely in the use of treatment of acute asthma. I think it's also important to emphasize that the preceding article in the same issue of The Lancet was an RCT of 6 months of use in people with uncontrolled asthma in the community or in specialist clinics, and this was chronic use. And the conclusion from that study was that initially people felt a bit better in themselves, but the objective measurements didn't really change very much, and they had no significant advantage. So this early evidence was that we could use steroids acutely, but chronically, they weren't really making much of an impact on most people with asthma. And I think that's worth just thinking about at that stage, how widely steroids have become used outside the emergency department. So this slide is probably the most important slide of the whole talk. So this is all of the high quality trials of prednisolone in primary care. So we really don't know how well steroids work when they're taken out of that 1950s emergency department setting. There are some small studies that suggest that they may be of some benefit, some small studies that suggest they may be only as effective as increasing your inhaled corticosteroids, but we really don't have that good understanding of what its role is outside the ED. And again, I guess I come back to this point. So this about the rapidity of adoption. that this is a chart of the number of years that drugs have spent between their first in human studies and their approval by FDA for general use. And you can see that for many drugs, it's about 10 to 15 years. And in these studies, we were talking about a year or two before it got widespread adoption. So we'd really let the horse out of the stable or the toothpaste out of the tube very, very quickly. And I think that's part of the reason that by today's standards, we had a very unregulated, widespread use of steroids. This was unfortunately made a little worse by the initial guidelines that started to come out in the late 80s and early 90s. And I'm picking on this BTS guideline, but there are other ones as well that say the same thing. And the key point from a lot of these guidelines is that patients who had required or were likely to require steroids should be trained to self-initiate them. So this is a very different circumstances from where the evidence base lies. And it obviously very much down to the individual patient's understanding of when they felt that the steroids were necessary. So again, very widespread use of OCS made even more widespread. But of course, steroids are not without their ill effects. And so this is a paper from 1955, which starts off by saying it's been obvious from the first steroids should be used at a minimal dosage level. So the side effects they list there and other ones in other papers very readily recognized that this was a class of drugs with significant side effects and that we should work hard to minimize people's exposure. However, they do say that the long-term treatment at a high dosage level has hazards. And I think that's probably been our get out of jail card for a long time, is that we didn't really understand what was meant by a lot of steroids. How much is too much? How much is a lot? And that's something that's really changed in the last 10 years. And it's really spurred us on to take more action on this front. So as I'm sure you'll all be familiar with, there's this study from David Price and colleagues, which took people in primary care from the databases OPCRD and CPRD, adults with asthma, and looked at people who'd had systemic corticosteroids and people who had not, and they had 24,000 match pairs of those individuals, and at least 2 years of follow-up in primary care in which to observe whether they came to any ill effects that may be related to that steroid exposure. Now, the first conclusion from the paper is something that's not unexpected, is that many of those things that we all recognize in clinical practice were shown to be more common in people who had systemic corticosteroids. Whether you had raw or adjusted hazard ratios, they were all more common. So a broad range of adverse effects, and there are some adverse effects that weren't specifically looked at in this study, which we also recognize from other studies, such as venous thromboembolic disease, that are important as well. The paper also demonstrates nicely that the more exposure you have, the higher your risk of these side effects is. So this is an example of just using the outcome of pneumonia, and that the higher the amount of steroid exposure cumulatively, the more likely you are to have it. So if you had 1 gram or more of steroid exposure, you were substantially more likely than the non-exposed people to get pneumonia. And a similar pattern is evident from the rest of the study. From the rest of the ill effects. So if we decide that 1 gram or more is a harmful amount of steroids, well, how often does that happen, given all the other changes in asthma management have happened over the years? So Mark Hugh and colleagues undertook this excellent study in which they looked at people who had asthma and were prescribed preventative treatment, and over 5 years, about half of them were prescribed oral corticosteroids, and about half of those people received over 1 gram in that 5 years. So the exposure of over 1 gram is a common exposure. So I know that we can argue the details of the David Price's paper and the subsequent ones about exactly how much exposure over how much time and whether an interrupted series of exposures over a longer period is less harmful. But I think what we can all agree on is this level of exposure is both harmful and commonly seen. And I guess a reminder that, when steroids first came out, there was a very limited array of treatment that might be used alongside with it to prevent the next attack coming along. And the landscape has really changed. So we're having this heavy exposure to oral corticosteroids, despite us having potential things that can be helpful that have been introduced in more recent years. And it's not just the medication context that has changed over time. We also have different type of population. For example, the smoking prevalence has dropped precipitously, but the number of people who are obese has gone up a great deal. So I think we can all agree that the harm from steroids is common and multifaceted, that it's not helpful to give steroids to everybody acutely, and that steroids are widely used outside their evidence base. Self-administered use of steroids has been encouraged, and I think we can, there are limited circumstances in which we probably should have been encouraging that. And the context of how we use steroids has changed greatly. We understand so much more about asthma than we did, and we have so many more other things that we can do. And I think that brings us on to the oral corticosteroid stewardship. So in the general sense, stewardship is defined as responsible planning and accountable management of resources to maximize the overall long-term benefit to the community. And these definitions are actually part of documents that are enshrined in law if you work in the public services, that we have to do our best with what we've got. There's a limited pie of resources. And so stewardship of OCS is not just about making sure that we do the best for the patient in front of us. It's about not causing trouble down the track that might take away clinic appointments, inpatient beds and budgets away from other people with other conditions. If we do better, we benefit people in front of us with asthma, and we benefit more people who have other problems as well. So thinking about some of those principles of stewardship now for the next 10 minutes or so. The first one is GIRFT, getting it right first time. As with everything in medicine, if you start off down the wrong track, you can follow guidelines and things and end up in a real pickle. And I know that people are busy, and I know that we're all time limited, but if we don't have time to do it right the first time, when will we have time to go back, fix the mistake, repair the harm, and do the thing we should have done in the first place? So if we say we're too busy, or we need to get this person out of my GP surgery, out of my emergency room, out of my clinic room, what we're really doing is saying somebody else can sort that out. And I think all of us need to be better at taking more responsibility for that. We can see that everybody's under a great deal of time pressure these days. Everybody is restricted by what they get reimbursed for. And we've shown these kinds of statistics before, that the number of people having spirometry in Australia is pretty low, considering how many people have got asthma and COPD. And when the pandemic came along, the number of reimbursements of spirometry dropped and hasn't recovered fully. So we know that we are not doing as well as we should be and could be doing in terms of getting diagnoses that are solid before engaging in treatment. You've probably seen papers that come from the UK and Canada that confirm that if in people who have been treated for asthma and are still treated for asthma, you cannot go back and confirm that diagnosis with tests in about a third of people. So there's a lot of people out there who are having symptoms that are not driven by their asthma. So they're treated as asthma. They don't do very well with standard asthma treatment because it's not really asthma that's the problem, and they get labeled with difficult asthma. And they have a pattern of oral corticosteroid exposure, which often includes multiple bursts, people trying weaning courses, patients themselves instituting low-dose continual steroids. So they're heavily exposed to steroids, and we've seen this in a variety of conditions. So getting it right first time is a really important consideration. The second key thing, as with everything in medicine, is to keep it simple. So do all the simple, basic, one-size-fits-all things first. So being able to answer a sort of exam type question about what interventions reduce asthma attack frequency is not the same as having implemented those strategies in your practice. So if I were to ask everybody on the who's listening to the webinar today, what is the most important thing that anybody can do for their health, if there's just one thing that they could do, then I would expect most people would say stopping smoking. That is the most important thing that we can all do. However, plenty of publications have shown that we are bad collectively in both primary and secondary care about describing what smoking habits people have. And we are very poor at actually implementing smoking cessation strategies. So if people stop smoking, their risk of having an asthma attack drops by about 50%. And so we're missing a huge opportunity. And you can see this in the ABS smoking statistics for Australia. People that have asthma on national statistics are more likely to be smokers than people who don't. And I think that's a really indictment of how collectively we have not worked as hard as we could on this front. The second most important thing for asthma, I think most people would suggest is taking inhaled corticosteroids, taking preventative treatment. And again, there have been plenty of studies across the last few years showing that this is not going as well as it could be doing. The most up-to-date information that I could find was on a web-based survey of about 6,000 individuals from Helen Reddell's group. And they asked people if they'd used inhaled corticosteroids in the last 4 weeks, and the majority of people with asthma had not. Now, I appreciate that's kind of a weighted sample, so the exact number will be not correct, but it's a very worrying statistics that we have not got this message through that people need to be taking their basic treatment. And part of that is that we're not explaining the relevance of these treatments to people clearly enough. And the campaign about smarter oral steroids from Asthma Australia includes some really nice infographics and patient-facing materials to try and explain why inhaled corticosteroids are more beneficial to people and have a lower array of side effects than oral steroids. So I think we ought to have our little go-to group of figures or charts or infographics or leaflets that we can advise people with about why this is so important. The third aspect of the stewardship is to treat what the patient has wrong with them. And so we recognize that asthma is a heterogeneous problem. Asthma is an umbrella term. It isn't really one disease. And so if you have that umbrella term of heterogeneous disease, you need tailored interventions. You can say stopping smoking is good for everybody, but other things are only useful in certain circumstances. And sometimes this is about the type of asthma people have. So we knew from the 1950s, from this paper from Harry Morrow Brown and others, that the type of asthma somebody has was very important. So he took 90 of his patients, looked at whether they had eosinophils in their sputum or not, and about a third of them had non-eosinophilic sputum, and he gave them all prednisolone. Unsurprisingly to us, now, the people who had eosinophils in their sputum all got better, and the people who didn't have eosinophils in their sputum, almost all of them had no benefit. And I think it's really a striking finding that we haven't acted upon that for decades after that paper was published. So it's important that we identify and address issues that drive cough, breathlessness, and other symptoms that might prompt some steroids to be given out. And there are things that I think that can be done whether in primary, secondary, or tertiary care by everybody. And so if you want a little mnemonic to remind your junior doctors, I'm going to suggest R2D2, reflux, rhinitis, deconditioning, and dysfunctional breathing. Things that can be easily treated in a GP practice, for example. We know that people who have uncontrolled rhinitis are at double the risk of having OCS in the next couple of years. We know that people who've got dysfunctional breathing will benefit from online breathing retraining. There are things that can be done to improve people's symptom burden and reduce their risk of coming to OCS. If you do prescribe some steroids, obviously we want to minimize the exposure that people have. So guidelines now have coalesced around 37.5 to 50 milligrams of prednisolone for 5 to 10 days. Most guidelines will say 5 days, but some do say 10. But there's certainly no good data to support using bigger doses, and certainly not that tapering over a longer period is helpful, because they do really expose people to a lot more in the way of tablets. We have this additional problem in Australia that we might think of as standard oral corticosteroid course being 50 milligrams times 5, 250 milligrams. So that's 4 lifetime courses is a gram. But in reality, the patients often get dispensed a much larger amount of steroids, a standard pack of 30 tablets or something similar. So in actual fact, the patient has got steroids that they can take between times, and so their cumulative exposure is much higher. And as we discussed already, the more steroids you have, the higher your risks are. So it's an important thing to be super clear when we're prescribing it. We don't want any more dispensed than we are recommending. And again, involving people with asthma in those decisions, explaining why we're trying to reduce their OCS use, providing them with information such as this leaflet from the Severe Asthma Toolkit about why this is important, about why we're trying to minimize exposure. There are obviously a handful of people who are on long-term OCS. And so the general good practice points around getting those people down are a protocolized approach. So we locally use the Penente weaning regimen, but there are other ones that have been published. We use a multidisciplinary team with doctors and nurses and doctors outside respiratory, including endocrinology. And we're guided by objective markers of disease activity and of adrenal insufficiency. So it can be done. There just needs to be a clear way of doing it that everybody can follow. If there are people who are having courses of oral steroids, it's important that they get referred to a specialist early, because we know that specialist multidisciplinary services are effective in reducing future courses of steroids. However, this doesn't happen as often as it should. There's another CPRD study looking at, it was 282,000 people with asthma, of which 23,000 had either frequent OCS or are on very high dose ICS or were uncontrolled on 3 preventer medicines. Out of every 100 of those individuals, only 8 had been referred to a specialist. And of those people who had been referred, the wait times were significant. The average wait time between being eligible for referral and being referred was 880 days. I think it's important as well to emphasize that this is not a GP access issue. I'll just skim over this data, but in the UK, there are surveys around how accessible GP services are. And if you plot that access score against admissions, there's no correlation at all. So it's important to say this is something that can be fixed wherever you are. And it can be fixed by improving the push, making sure that people themselves know when they need to see a specialist, that GPs have very clear guidelines for doing so, and a pull that the specialists are engaging with people and with primary care to get those people across. So I would hope everybody would think about their local written policies and engagement strategies for making sure this happens. It's also important to emphasize that there's lots of stakeholders involved. There are walk-in centers, there are emergency departments, there are various hospitals in an area, there are various private specialists involved. And a lot of those individuals have to face perverse incentives. That, for example, you get more money from an emergency department attendance than you do from an outpatient attendance. There's a lack of clear funding for some things like community services. And there are practical and IT barriers there. So it is hard work to get these guidelines in place, but it is certainly very worthwhile. And then the final principle I'll come to very briefly is just to say, don't forget that once people have gone over the toxic threshold, they need even more support. So again, we all need to have very clear protocols and plans about when are we monitoring people's bone health, how are we monitoring their glycemic control, the adverse effects on mood that steroids have, weight gain, cardiovascular risk factors like hypertension and hyperlipidemia, and the eye problems like cataracts. So again, very important that we have clear written guidelines that everybody follows and can be audited against when we're dealing with these people. So to summarize all that together, oral corticosteroids do have a benefit in asthma, perhaps not quite as widespread as we have been using them. Lots of people with asthma are exposed to harmful amounts of oral corticosteroid. These are hundreds of thousands of people across Australia who are at significant risk of side effects, and these are not getting addressed properly. But things have changed in the last 70 years, and we've got a diverse range of evidence-based interventions. And so primarily what we have is an implementation problem. We have things that work, but they're just not reaching the right people. And if we do manage to implement these things, you don't just get improved outcomes for patients with asthma, but you also have reduced stress on healthcare systems. I'm going to stop there. Thank you for your attention.
Very nice presentation. Thanks, John. There is one question in the box, but I think if the questioner doesn't mind, we'll leave it until the panel discussion. But please, I didn't say as we started, please, if you do have questions, pop them in the Q&A box, and we will come to those during the panel discussion. Such a great, systematic and well kind of stepped through process for improving OCS use in adults. Thank you very much, John. So we'll now move on and think about it from a paediatric perspective, looking at the use of oral corticosteroids in children. So I'll introduce Associate Professor Shiv Shanthikumar. And as I said earlier, he's at the Royal Children's Hospital in Melbourne. He's a clinician researcher, and he works with a lot of people with a lot of children with asthma. So Shiv's got a particular interest in oral corticosteroid stewardship among the paediatric population who have asthma. So over to you, Shiv, to hear your perspectives. Thanks very much.
Thanks so much, Vanessa. Thanks very much to the TSANZ and Asthma Australia and the CRE for the opportunity to speak today. I'm very excited, and it's a very impressive talk that I now have to follow on from, so I will do my best. But yeah, I'm going to focus on the paediatric lens to the problem of oral corticosteroid stewardship. So just some disclosures. I have received some honorarium for speaking at an educational event for Sanofi, and I will mention the benefits of asthma biologics in a certain context in the talk today, so bear that in mind. Just in terms of the outline for the talk today, I'll just briefly touch on oral corticosteroids in childhood asthma in terms of their indications and risks, and then some thoughts on the different aspects of stewardship in paediatric practice. So if we just start off by thinking about indications for oral corticosteroids, and I've divided this up into acute asthma and kind of chronic asthma. And also in pediatrics, we often end up further dividing our patients into preschoolers, primary school, and adolescent age patients, because they're all slightly different, and the approaches are slightly different again. So at a very high level, these are screenshots taken from the Asthma Australia handbook, and it talks about how for adults with acute asthma, they have a dose that they recommend there, which is between 37.5 and 50 milligrams of prednisolone for 5 to 10 days. Whereas the recommendations are different in children. So in children aged 6 to 11 years of age, they talk about recommend giving 1 milligram per kilo for just 3 days. and in children in the preschool age group, in the 1 to 5 year old age group, the advice is further nuanced. So I guess when we think about prescribing for acute asthma, there are areas of contention in paediatric practice. So firstly, the dose. So do you do weight-based dosing, as in 1 milligram per kilogram, or do you just give a set dose, i.e. 50 milligrams? If you are going to do weight-based dosing, some people would say the first dose should be 2 milligrams per kilogram because there was a trial showing that was beneficial, whereas others would recommend 1 milligram per kilo. And yeah, interestingly, if you look at asthma guidelines from around the world, they all recommend something slightly different. The duration, so as we've seen in adults, 5 to 10 days is mentioned, but in pediatric practice, we often talk about 3 days, but are all 3 days needed? So some people would say give the first dose and then only give subsequent doses if needed each day, which might mean a course that's less than 3 days in duration or longer than 3 days in duration. Or do we just give a 3-day duration? What is the role in preschool children? And I think we could probably talk for many hours about that because it's very hotly contested. And I'll present a bit of data on that on the next slide. And what about the role of parent-initiated prednisolone? So John mentioned the idea of how guidelines in adult practice have perhaps encouraged the use of self-initiation of prednisolone, even though that wasn't really how the initial trials were designed. But in children, I guess the analogous practice is parents giving the prednisolone at their own discretion. And well, I'll touch on that. So just specifically around the role of oral corticosteroids in preschool children with asthma. So as I mentioned, it is a point of contention, and this was a systematic review that was published last year, and they screened all the evidence regarding this question from 1994 to 2020. And essentially what they showed, I've highlighted the significant findings. So compared to placebo, prednisolone was associated with a greater improvement in a symptom severity score at 4 hours, but that change was no longer significant at 12 hours of duration. And the other significant benefit was that it shortened the duration of a hospital stay by about 4 hours. So really, I think the take home for this is that the only evidence to support prednisolone in the preschool age group is using it in the hospital setting with the aim of reducing your hospital stay by a few hours, which, given the number of children who present to emergency departments and hospitals around the country, that's a significant saving. But really, it means that the benefits in terms of symptom scores are no longer significant at 12 hours. So the role for prednisolone in preschool asthma in the community is really there's no evidence to support that. The next question I mentioned was around the role of parent-initiated prednisolone, and so this was a trial that was run in Victoria, in our state, and by predecessors in my department. And what it did was children were parents were randomized to either self-initiate a course of prednisolone for their children or not. And what it showed in this randomized controlled crossover trial was that the benefits of parent-initiated prednisolone were really subtle reductions in asthma symptoms, healthcare resource utilization in terms of unplanned GP visits and school absenteeism, but not in more significant outcomes such as avoiding admission and emergency department presentation. And the authors of the trial concluded that the benefits were subtle and should be balanced against the potential side effects of repeated courses of oral corticosteroids. And I think this study was published at a time where probably we weren't as aware of the threshold of 1,000 milligrams or being a toxic amount of exposure to prednisolone. And I think that conclusion might even be more strongly worded now, if we had that evidence at hand. In terms of in the chronic management of asthma, what are the indications for oral corticosteroids? Well, certainly, I think as John nicely outlined, in the past when we had a limited a number of tools in our toolkit for managing people with severe asthma. You know, you had to reach for oral corticosteroids relatively quickly, whereas these days we're very lucky to practice in an era where there are many more resources, and as such, you know, guidelines such as GINA would refer to maintenance oral corticosteroids as a last resort. And so in children, there is evidence to support the use of you know, in addition to standard things like inhaled corticosteroids and long-acting beta agonists and leukotriene receptor agonists, things like azithromycin, long-acting muscarinic antagonists, and biologics. So in summary, what are the indications for oral corticosteroid in the management of children with asthma? Well, if we divide it up between the preschool, primary school, and adolescent age group, well, in the chronic in patients for the management of chronic asthma, it's only ever a last resort. In adolescent asthma, guidelines which suggest they are reasonable to use for acute exacerbations. In primary school, yes, for acute exacerbations, but probably not for parent-initiated asthma, parent-initiated use. And in preschool is only for severe exacerbations, so only really in the emergency department setting and not in other settings. Well, I guess when we're talking about indications, we also need to consider risks. So what are the risks of oral corticosteroid exposure in children? Now, I'm just going to start with this slide, which is many people, or specifically pediatric respiratory specialists, will be very familiar with this figure from the left, which is the chart that outlines the trajectory of lung function development across the lifespan. And the graph in blue is what the normal course is, which is rapid development of lung function across your first 2 decades of life, your FEV1 peaking at about 20 and then steadily declining thereafter. But chances are you'll never get symptoms of that and you'll die from something else. However, things like poorly controlled childhood asthma will cause slower attainment of lung function across your first 2 decades of life, resulting in a lower peak lung function and a quicker decline to symptoms and death. And we think about this a lot as pediatric respiratory specialists or pediatricians or GPs or people who are trying to manage asthma the best we can so that we not only maximize the child's quality of life in childhood, but we also protect their long-term health. But we often think about protecting their long-term lung health. I guess what I've in thinking about the role of oral corticosteroids and my role in prescribing those, I'm trying to lift my awareness a little bit and advocate for others too, to also think about, well, what is our responsibility or what is our role in the long-term health of our patients outside of the lungs? And so this figure comes from the work that Asthma Australia has done and highlighting all of the side effects of steroids, which we all know about. But we need to keep in mind that if we're prescribing a preschool child with prednisolone, which we do very often, we are increasing their risk of all of these complications across the life course. And we're doing that with relatively low prednisolone exposure. So I think we need to keep that in mind. In terms of all, is there evidence to support risks of oral corticosteroid exposure? So this is a study from a UK cohort. It's led by David Price, who led some of the work that John highlighted. So it's a large cohort from the UK. And what they did was they looked at GP prescribing databases. And what they did was they classified people as never using oral corticosteroids compared to a one-off use of oral corticosteroids, compared to less frequent oral corticosteroid use, which is where there was multiple courses of OCS, but with a gap of greater than 90 days between them, compared to frequent oral corticosteroid use, which is where the gap was less than 90 days apart. And they looked at a whole range of the known side effects of oral corticosteroids. And the median, in terms of the data that was available for them to analyze, the median follow-up duration was 8.3 years for the cohort that was exposed to oral corticosteroids and 9 years for the non-oral corticosteroid exposed cohort. And what you could see is that even in the pediatric age ranges, so 4 to 12 and 12 to 18, your risk of an adverse event or an adverse outcome related to steroid exposure was higher in all of the oral corticosteroid groups. So there are definitely, our children are definitely coming to harm even from one-off oral corticosteroid exposure. Now, what is how much is harm? And I think John made this point, like how much is harm, and so I think he nicely illustrated the evidence of 1,000 milligrams of cumulative exposure across a lifetime being associated with harm. And what I just wanted to put that into the context of was, well, I think actually in pediatric practice we can hit that figure quite quickly. So if we look at the average weight of people, the 50th centile, if we look at a growth chart for these different ages, and we look at what is the cumulative exposure accrued with a 3-day course of 1 milligram per kilogram dosing. And then if we just think about people having 1 to 2 courses of prednisolone per year, and you add that up, you see very quickly that people are going to hit that 1,000 milligram cumulative exposure threshold well before they ever get to adult practice. So I've seen some of my adult colleagues when talking on this topic say, oh, we need to monitor and include in our letters what the cumulative exposure is to prednisolone. And I think John mentioned, we need to support people who've reached the toxic threshold in our practice. And my kind of guilty thought is that actually I'm pretty convinced that all of our patients that we transfer over to adult services probably have hit the 1,000 milligram exposure mark, and we need to be cognizant of that. The other thing that I just want to highlight, and this kind of also relates to a point John made about making sure we educate and empower our patients, is there's also the long-term behavioural aspect to how we educate and almost train our patients and their families. And so one of the things is that when we're managing children, we're managing a lifelong condition. As children with asthma, we're managing a lifelong condition. And what we kind of train them in as appropriate asthma management in their early years is probably how they're going to manage their asthma for at least their primary school and adolescence, and if not for the rest of their life. And I think, unfortunately, at the moment, the way that we're training families is to be reliant on Ventolin and using as much Ventolin as they can, and then when that fails, using as much oral corticosteroids as they can, and not on anything else. And the data to support that idea comes from this study that I was very fortunate to be involved in, but it looked at families who had a child who was admitted to one of 3 Victorian hospitals, which span tertiary, metropolitan and regional areas. And it was this specific piece of data was regarding some qualitative interviews that were done with caregivers about how do you use primary care, what's the role in asthma management. And really a couple of the representative quotes here is that, when my child is unwell, we go to the GP to get a script for oral corticosteroid, or the other, that was really one of the main roles. And when we looked at other data sources like GP billing data, we saw that really families just don't access GPs for routine asthma visits to manage asthma as a chronic disease. The pattern of behavior is about accessing it for acute healthcare visits to get a script for prednisolone. That doesn't work, they go to the emergency department. And then the message that they get from centres like mine is that, well, that's the right thing to do, just keep managing asthma as a series of acute episodes and not as a chronic disease. And so I think we really need to shift the behavioural aspect around how we manage asthma, but I'll talk a bit more about that in a second. So if I think about oral corticosteroid stewardship in paediatrics, a lot of this is going to touch on similar themes to what John raised. But firstly, we should use oral corticosteroids in an evidence-based manner. So for children with asthma, we should only use it in the way that the evidence suggests, which is avoiding use in preschool children in the community. So only prescribe it to preschoolers once they hit the emergency department or thereafter. really reconsider the role of parent-initiated oral corticosteroids. I will admit that this is something that I commonly did, or maybe not commonly, but did relatively often in my practice not so long ago. But after looking into the evidence, the modest benefits associated with it and the significant harm even from relatively low oral corticosteroid exposure, I'm really stopping that and avoiding maintenance oral corticosteroids at all costs. So one is only use them in an evidence-based way. The second thing is doing everything we can to prevent exacerbations, so to prevent the need for them. And this echoes things that John said, but you know, many people will be familiar with this publication, which was the Lancet Commission on Asthma from about 2020. One of the points was around having a zero tolerance for asthma attacks. And, you know, when someone has a heart attack, they will automatically undergo a very rigorous assessment where every risk factor is identified and everything to prevent a second heart attack is done. And we need to do the same thing after a single asthma attack. So in pediatrics, that starts by doing the simple things. And so relating to the Girth principle, I hope I pronounced that right, is making sure the diagnosis is right. So I think there's a lot of misdiagnosis in childhood asthma. And so getting the diagnosis of the symptoms right, looking at treatable traits and the things that are relevant to pediatric practice in particular, things like allergic rhinitis and obstructive sleep apnea. You know, doing simple things like inhaler technique. So, you know, there is a study that involved around 300 children who had their inhaler technique assessed, and only 8% of children could use a metered dose inhaler correctly. So, you know, rates of incorrect inhaler usage is very common. And so do we have evidence that, you know, doing the basics of asthma management is associated with a steroid sparing effect? And I would say we do. So this is just one paper. This is from a clinic in America. There are lots of kind of similar level studies, which this clinic was just a clinic that was not a tertiary level severe asthma clinic. It was a clinic that involved a pediatrician, a nurse, and a pharmacist, which just aimed to do an asthma assessment and some asthma education, and doing, that circle of asthma care as highlighted on the previous slide. And what you could see is that in 50 children, when they looked at the number of systemic corticosteroid courses over a year, there was a significant reduction in oral corticosteroid courses after, a clinic where just the basics of asthma management were done. So that's definitely one thing we can do to improve asthma control, reduce severe exacerbations, and thus reduce oral corticosteroid exposure. Another thing we can do is that I think is, a newer thing in pediatric practice, or for adolescents at least, there's evidence to support it, is the use of anti-inflammatory reliever therapy, either alone or as part of a maintenance and reliever regime. And so the figure on the left is an adolescent-specific sub-analysis of the Sigma studies, which nicely highlighted that the use of as-needed budesonide formoterol provided superior outcomes with regards to the number of severe asthma exacerbations as compared to as-needed SABA alone, and the equivalent outcomes to daily inhaled corticosteroid plus SABA as needed. So that's one way we can reduce severe exacerbations and thus prednisolone exposure. And this is a systematic review that has pulled all the adolescent-specific data, as well as adult data actually, but regarding the use of budesonide formoterol as part of a maintenance and reliever regime, so in the more severe asthma, showing that there was a reduction in the number of severe asthma exacerbations and a prolonged time to first severe exacerbation, thus reducing oral corticosteroid exposure also. The last thing, the last thing is for the most truly severe patients with asthma. One other option we have is asthma biologics. So this is a figure from some research that we did at our asthma clinic, looking at 35 children who were treated with biologics for severe asthma. And in the previous 12 months prior to biologic initiation, the median prednisolone exposure was 610 milligrams. So keep in mind the thousands, the lifetime threshold. In 1 year, they were getting 610 milligrams. But afterwards, biologic initiation, in with the 12 months, the median steroid exposure was 0. I should know that most of this data was collected in the era where PBS required 500 milligrams in 12 months of prednisolone to be eligible for a biologic. That criteria has thankfully been removed. The other thing, the last few things I wanted to touch on is more thinking about how we might implement some of these things or how we might achieve these goals. So the thing with asthma is it's managed across the healthcare system, and really we almost need people at every single level to be helping us on this crusade to reduce oral corticosteroid exposure via either increasing evidence-based use and or improving asthma control. And I like this framework that comes from the NHS, which is that it kind of highlights all the different people who are involved in asthma care and different levels of capabilities or different actions we would hope they would be able to implement. And it's, at the very highest level, we've got, tertiary level severe asthma clinics who, should be able to do the severe end. But at the very, at the lowest tier, we have people like GP receptionists and leaders of children's clubs who just need to have the basics of asthma management and some basic knowledge and being able to signpost to what resources are available. And it would be great to think about how across this spectrum we could, get support for reducing oral corticosteroid exposure. And the next thing I wanted to think about was the role of innovation. So, John mentioned how important things like social media and TikTok are. None of what I've said, or to be fair, what John has said was particularly new. And yet we haven't been able to shift the dial. And I think if we just keep doing the same thing, as in updating asthma guidelines and hoping that disseminates into the community, like we're just going to keep seeing the same results. So we've got to think about what novel tools and levers do we have to help tackle the problem. And I've just listed some things on the slide there, and perhaps we might talk about them a bit more in the discussion. And the very last thing is I just think we need to think about oral corticosteroid stewardship in the bigger picture of asthma management. And so I came across this term recently called syndemics, and that's where you've got multiple epidemics that are happening at the same time. So 2 or more epidemics, but they should be, they need to interact and be related to each other and share upstream factors that drive their co-occurrence. And when I think about asthma, I feel like there's an epidemic of oral corticosteroid overuse and inappropriate use, but I also think that there's an epidemic of SABA overuse. There's clearly an epidemic of climate change, and the need for sustainable asthma care and the role asthma care plays in that has been, is clearly relevant. There's an epidemic of obesity, there's epidemics of social inequality, and all of these things are kind of related. And I think that perhaps we need to think about what can we do to tackle all of them simultaneously rather than trying to pick them off one by one. So that's all I had to say. I'm going to stop sharing my slides and hand back to Vanessa.
Excellent. Thank you, Shiv. And thanks to both presenters. We've got a panel discussion now. So I will ask all our panelists to turn their cameras on. We'll invite John and Shiv to stay here for the panel discussion. And I briefly introduced Desley Hegney earlier before we began, but it's really great to have Desley here because she's here to present the experience of a person with asthma and kind of think about, how people with asthma have experienced the management of their disease, but also the use of oral corticosteroids over periods of time. So that will be a really important perspective, as will the perspective of primary care. So I'm delighted to introduce Professor Nick Zwar to the panel as well. Now, Nick is currently the Executive Dean at Bond University in Queensland, but he has a background in medicine and as a general practitioner and a primary healthcare teacher and researcher. And Nick's been working in the field of respiratory and cardiology for a number of years in relation to a primary care perspective has been integral in looking at multimorbidity and approaches to care, and has a particular focus on smoking cessation. So welcome, Nick. It's great to have you here so that we can have particularly multiple perspectives on this issue. We do have a number of questions online, but before we go to those questions, I'd just firstly like to kind of introduce some of the perspectives of both Desley and Nick in the panel discussion before we go to the specific questions. And Desley, if I can start with you, can you tell me in your experience of having asthma, have you had exposure to oral corticosteroids?
Yes, actually, I'm 76. So I think John's presentation started about when I was born in the 1940s. And I had eczema as well. And the treatment then was an adrenaline inhaler. And I'm pretty sure the doctor used to give me IV cortisone or something like that when I listen to how I should be managed today. I feel really disappointed and quite upset because I'm not managed like that at all. And I've been through it all. I've been through the Intals and the Elixophiline and the Theophylline and the, cup of coffee helps because it's got Theophylline in it. One of the things I didn't hear mentioned was that I've been told that and I did have a challenge done at Royal Prince Alfred when I was in my late 30s, to say that I have salicylic acid triggered. I'm a salicylic acid triggered asthmatic. So I don't know what Sav and John have to say about that. But if I could be managed even now, the way that John and Shiv or have my grandchildren or great grandchildren managed, I would be terribly excited. But it's just not happening. And one thing that I think maybe when we're talking about how do we get things through to people is to try and have more informed consumers, which Asthma Australia is trying to do. But the toxic dose OCS stuff, we've struggled with our panel of consumers that have worked on that. And basically, because we don't want to frighten people, misinformed people, I think, are probably worse than well-informed people. And so, but I mean, how do I get through even to my GP? I go to a specialist. There's all sorts of things that, and it's been isolating for me as a child, because in those early days you weren't allowed to go out. You weren't allowed to swim. You weren't allowed to go out in the night air. So I had a very isolated childhood because of my asthma. It didn't affect me, fortunately, physically, but when I look at all those side effects of those OCSs, I can just about tick everyone off now. So, yeah, I think it's been fantastic to listen to this presentation, but I feel sad. I don't only feel sad for myself, but I feel sad for all the people. Particularly, I live in a rural area, and I live in Toowoomba, and there is two private sector respiratory specialists here, for a population of about 300,000, if you think of the catchment. And they can't get these people to come and work in rural areas. So the other problem is the cost to rural people, and trying to get the message through to people in rural remote areas, because just travelling is really, really difficult. And I don't think telehealth is the answer, to be perfectly honest. So I'll stop there. Yeah.
Thanks, Desley. And I think you identified a really important point, or a number of really important points, but one of those was, I guess, the knife's edge in terms of how we communicate this to the community. And by the community, I mean people with asthma and carers and family members, but also to our health professional colleagues as well, because it is important that people have oral corticosteroids for acute asthma. so we don't want to scare people, and we don't want to have people not take them or kind of refuse to take them for those reasons. So that messaging is really important, and we might come back to discuss that in a moment. Nick, I'd like to get a bit of a perspective from primary care as well. And I mean, this is a really important issue, and I think there's some data that's been published that actually says, you know, it is the respiratory specialists that are leading the charge in terms of who prescribes the most amount of oral corticosteroids if you look across all of the inflammatory diseases. But patients do come to primary care. The way that's their first port of call for an acute episode of asthma. The way we prescribe oral steroids in this country is by, as Shiv said, or John, I think it was actually, giving 5 days for an acute episode, but providing a script for a bottle of prednisone with 30 tablets. So what do you see as the biggest issues and challenges and potential solutions within a primary care environment?
Thanks, Vanessa, and thanks for those presentations, Shiv and John. Look, I think, as has been pointed out, there's a number of competing challenges here, and the context is important. As been mentioned, people in Australia have access to SABA over the counter in pharmacies, and in that context, I think that has promoted the idea that asthma is something you don't really need to see a doctor about very often unless it's out of control, and you just go to the pharmacist and get your short-acting beta agonist. And I think that message has permeated, even though a lot of groups like Asthma Australia and the National Asthma Council have really tried to get the message across about getting better asthma control by using preventers, corticosteroids, and trying to minimize the dose of those. That's a really hard message to get across when a lot of the community don't see asthma as a long-term condition that needs regular care. They see it as a periodic problem that you do something about when it's troubling you, and then you wait till it troubles you again. So that has been really hard message to get through. And I think the difficulties with access to both primary care and secondary care exacerbate that. And it's harder now than ever, probably, for people to get access to affordable primary care, which is really unfortunate. And there's a whole lot of reasons for that. And as been mentioned, access to spirometry, good quality spirometry in primary care is really difficult. It was already hard before the pandemic. It got a whole lot worse during the pandemic. And the infection have not been updated, and the message that's going to GP practices is still, this is a high-risk procedure. You've got to do all of these precautions if you're going to do spirometry in practice, and that's expensive and time-consuming and puts people off re-establishing a spirometry service. So there's all sorts of contextual factors that I think add to the problem. And I guess just the historical perspective is interesting, and thanks to John and Desley for that, because, you know, I think in my practicing lifetime as a primary care doctor, in the 1990s, we're seeing lots of kids with asthma, you know, and adults too, but for whatever reason, asthma. And asthma was a national health priority. You know, we'll remember those days. But we didn't prescribe oral steroids much, from my memory. You know, we did lots of things, but oral steroids were thought, ooh, pretty risky. And then it kind of became a bit normalized that it was okay to use them for short term, didn't need to taper, you know, which actually probably made it easier, because, you know, I used to think you had to taper them, and that's complex and hard to explain to patients, and, you know, etc. And so, interestingly, that kind of slightly normalized the use. And I do agree with all the speakers that the risks have not been well enough communicated, and that knowledge of risk and cumulative risk with dose over the lifetime needs to be better understood by clinicians and by patients, including parents. And I guess another comment, I don't think the bottles of ReadyPred for croup in people's fridges at home are helping, because it sits there, it's still available. Parents think, oh, work for croup, you know, child's got a cough, why not fish it out, and we might all get a good night's sleep.
Yeah.
And I think that's a real problem, which probably hasn't been talked about enough. I can see some nods from John and Shiv, because I don't think parents realise that this is a very powerful medicine. And part of primary care's job is to get that across, and specialists too. I don't think we do that as well as we need to. So there's a whole range of things, and I think Desley's point about availability of advice, and even in cities, you know, if you want to refer someone into a public respiratory clinic, particularly if it's a paediatric one, she would know how long the waiting list is. It's going to be a couple of years sometimes. So, you know, availability of advice from secondary care, if people cannot afford or don't have access to to go to a private specialist, is really difficult. And that, in my time as a GP, has got harder, not easier. So the context matters, and the context is, it's not an excuse, but the context is relevant to how we think about some of the solutions.
Yeah, and I think you really highlight that it's not a single kind of intervention that we need to kind of come up with. And as John and Shiv kind of presented, it's very multi-dimensional in terms of the different principles and steps that are needed in order to overcome this problem. And I know from having many friends who have young children, just hearing them say, well, I just get the Ready-Period out of the fridge, and it's a terrible issue. Let's go to some of the questions online. And one I think we'll answer pretty quickly is there evidence for cumulative dose of prednisolone in children? And the risk of systemic adverse effects. And I think that question was asked during John's presentation. Shiv, you very nicely presented that in terms of the cumulative risk. But would you like to add anything to that?
Yeah, we probably don't have as good a data as the adult group do about, you know, the 1,000 milligrams being the, you know, a toxic dose, and then a dose response curve for many complications above 1,000 milligrams. I think there are, you know, and also I guess that what is also probably true is 1,000 milligrams exposure over 5 years the same as over 10 or 15? I'm not sure we know the answer to those questions, but the other thing is that, so I think it's reasonable to think, you know, 1,000 milligrams is going to be harmful because if we think about that in relation to a child's weight, well, it's actually even more exposure than what it is for an adult. And also it's a period of development. So, you know, you've got the effects of steroid exposure during development. So in my mind, I think it's reasonable to think if 1,000 milligrams is toxic in adults, it's going to be toxic in children. Maybe it's even less. I don't think we have the data as yet.
Thanks for that, Shiv. There's another question which is a little bit similar. Can you comment about the low cumulative exposure OCS use in asthma management? There are conflicting information that it may increase the risk of comorbidities, mortality, and unscheduled hospital visits, but others say it may be beneficial to certain patient groups, especially people with asthma and rheumatoid arthritis or polymyalgia rheumatica. Do we have any response to that question?
Yeah, I can take that if you want, Vanessa. Just to say that for clarity's sake, I tried not to present too much data. I realize we all get bombarded with graphs these days, but I think that, you know, there's very strong information about low OCS exposure causing harm. And I guess if you're going to read one more paper, there's a paper by Inga Skov, which looks at all of the people who are registered to have asthma in Denmark, about, you know, over 150,000 people. And they very nicely demonstrate that people are coming to harm from less than 500 milligrams of cumulative exposure across a variety of harms. And that was in the ERJ, sorry. So there's plenty of papers out there that show low exposures associated with harm. I think it's also important to emphasize that a lot of the other conditions have moved on. It's not just asthma that's moved into a biologic era. And so if you do go and look at the most up-to-date Australian rheumatoid guidelines, they specifically say do not use chronic oral corticosteroids. And the PMR guidelines say there is no randomized controlled trial comparing steroids with placebo. So there's no trial showing that steroids are the best thing to do there. It's just what everybody does. And I think there are some pockets of medicine which have moved on. and not all people are aware of that. And I think that's understandable. You can't keep across everything. And there are other areas where we need more information. And we have to keep remembering that people don't have asthma in isolation. They have lots of other things wrong with them. And so, yeah, it can be difficult when we're giving treatments that compete against other treatments for other conditions.
Yeah.
But general gist is, yes, bad news to have steroids.
Yeah. And we probably need to look at some lessons from those other diseases as well, in terms of how they're now treating patients earlier with biologic therapies and disease-modifying treatments. And maybe think, ask ourselves the question, are we waiting too long when people have already been exposed to far too many doses of OCS? What about lifelong experience of asthma? So those that are already exposed with the cumulative dose, are different side effects triggered at different levels? Does the duration of accumulation impact toxicity? We kind of addressed this one, didn't we? Yeah. And do other predisposing factors influence the side effects that might be triggered for an individual? So I think we addressed the length of exposure, but what about predisposing factors influencing the side effects? Do we have?
Yeah, I think that definitely is the case, Vanessa. I mean, you've got these large population studies showing that overall, or hundreds of thousands of people, the hazard ratio is this or that. But an individual who might be, vitamin D deficient or smoke or whatever, their risk of having osteoporosis or pneumonia or something will be different. And as long as we don't lose sight of the fact that these papers are a trigger for us to think about those conditions and risks and then factor them into our thinking with the individual, I think that's the kind of important thing I would suggest from that side of things. So it's, yes, there are different levels, but it's different for different people.
And could I just go on to say that the other thing that I take away is that there's almost two responses, and they're not necessarily mutually exclusive, but when you see a paper like that, one thing could be, one response is like, how do I keep using oral corticosteroids and just work out how to use them a bit safer? Or the other option is there another way that I can avoid steroids altogether? And I think that, and I can see like another question, the most recent question in the chat is around, the use of AI for personalized steroid dosing. And I think there certainly are small things, well, there certainly are things that we can probably do, I'm guessing across adults, certainly in pediatrics, to perhaps use steroids a bit safer. But I'm hoping the data or the information that we shared is that actually probably a lot of the effort is we now have so many tools in asthma care that the energy should kind of go into avoiding to need to use steroids at all. I personally, and I'd be interested in the rest of the panel, for me, that's probably like 75 to 80% of where the attention needs to be. And actually and then maybe evidence-based use of steroids, and then hopefully we're actually using very small amounts of steroids, and therefore you need to work out who's going to have more harm, or is 3 days better than 5 days or stuff. I feel like that's less the priority.
So can I just jump in there and comment? One of the other things I'm involved in is the Asthma Management Handbook, and I chair the Guidelines Committee. And we're having a discussion in the update the other day, very relevant to Shiv's point, about what would be the number, this is in kids, the number of times you've had to give oral steroids that would then trigger you to refer that patient. You're trying to do other things, trying to get the patient on the right relievers as well, preventers as well. And it's an interesting debate because it again goes back to practicality and availability of services, as well as, one might say, well, they should never have to have a dose. So even once, which would be enough. But then Shiv's clinics, that his list's already 2 years long, would be 15 years long, because that's just not workable. So it's a tricky one, because you have to kind of balance what's possible in the health system with what may be the ideal. But certainly there was a high level of awareness in the group about this needing to be a signal to try to get better asthma control if you're needing to give doses of oral corticosteroids.
Yeah. Desley, I see your hand up.
Sorry, I'm on mute.
And then
Yeah, so when I was working in Singapore about 12 years ago, and I went to get my 25 milligrams of prednisolone, the doctors there nearly fainted. And the highest dose prednisolone you can get in Singapore then was 5 milligrams. And they could not believe the regime that I was on my asthma plan. So I guess my concern and question to John and Shiv is, what are other countries doing about this? Because obviously Singapore's not giving people even 37.5 milligrams for 2 or 3 days. So I just wonder about how that fits.
Do you want me to go first? So,
thanks.
so I think part of that, Desley, might be that some countries only have 5 milligram tablets in routine use. So that certainly really makes it apparent to the user and the prescriber that it's a lot of steroids when you're having to count out 10 tablets. So I think that certainly was the case in the UK, and that was quite visually impactful. So even though the prescription might be the same, it didn't look the same. And I think you raised a very important point, that we have never really had good data around what is the most appropriate dose to give people of steroids. And I think there's been a lot of medications that we use that have been around a long time that we've never really questioned how much and when we should use them. The other thing to say, I think alluding back as well to some other points that were made, was, is this the best treatment to give at all for an acute exacerbation? I know it's what we've been doing for 70 years, but we've seen from a recent ABRA trial and others that other drugs are more effective. And if they were cheaper, like steroids are incredibly cheap, we'd be using them.
Yeah.
So I think there's part of it is, as Nick was saying, what's the best possible care you could have in a world where there was no restriction on some resources, and then what is the practical compromise that we can reach at the moment about what's the best care we can give.
We are running out of time, but I really want to kind of throw in a question around written action plans. There's one in the chat there, and so Nick was saying in the 90s they weren't giving as much oral steroids, and I was around at the time where, with that written action plans, we changed from doubling ICS doses to including a dose of oral corticosteroids as part of the plan. How are we going to manage? I mean, written action plans are done far better in children than they are in adults. But, what's our way forward when you consider stewardship with what we prescribe on written action plans in the future?
Well, can I just say, actually, I think that perhaps a relatively simple, I'd say this lever to pull, is that the many people use asthma action plan templates, and so perhaps removing options on those templates is one way that you can help to move people away from a certain practice. And so, for example, I think in an ideal world, from a pediatric perspective, it's purely a pediatric perspective, the evidence around doubling and changing inhaled corticosteroid dose is that does not work. Quintupling your inhaled corticosteroid dose didn't work in a primary school age trial. And oral corticosteroids, as we've seen, parent-initiated, doesn't really work. So actually, if the available asthma action plan templates for children didn't have that as an option, I think it would make life actually easier for the clinician filling in the template, and easier for them to do an evidence-based template, and easier for them to do a template that didn't include practices that end up causing harm. And I think that would be ideal, just to remove that as an option.
And
it's more nuanced in adults where the evidence isn't so clear cut, and it's probably more widespread in practice, I think.
yeah, John or Nick?
I would just raise that personalised asthma action plans have been shown repeatedly not to be effective in reducing OCS doses. Only if they're coupled with patient education are they effective. So I think it's the education bit that's the thing we neglect.
Mm.
And I think as long as that education thing is delivered well, then the chances of people using the steroids are reduced. And I think that's the most important short-term thing we can do.
Yeah. And there's a question about whether practice nurses actually are delivering patient education in primary care. But I think one of the problems there is that the practice nurses are juggling so many different kind of areas that they may not have the time to provide the amount of asthma education that's required. Nick, did you want to quickly?
Well, just a quick comment. I think, I think we asthma use of primary care nurses in asthma has a lot of potential, but we're not doing it well. I mean, you probably need someone in bigger practices, a nurse who has particular diabetes skills or particular respiratory skills and some time and funded time to do that education. That's not the way the system works at the moment. And unfortunately, until the sort of system and financial support for that changes, it's hard to see. I think the other thing that maybe can help is decision support systems, where you have a sort of template for that discussion. And I've been involved in one study where there was a evaluation of that. I think they do have potential. That was with Asthma Australia. But again, you need support, education for widespread rollout of that. And we haven't had that as yet.
Yes, but certainly one area in which we can kind of, try to develop more access to nurse-led education in some ways. There are a number more questions, but unfortunately we're going to have to wrap it up so that we let people begin their weekend. So please, I'm sure the online audience would like me to thank our speakers, John and Shiv, and our panel members, Desley and Nick. It's been a really great afternoon of both presentations and discussions, and I think really highlights the importance of this area and the importance of improving our strategies going forward so that we can reduce the burden on people with asthma and on the healthcare system, as John said. So thanks to the audience for attending this session and for your questions. Before we sign off, I'll just again thank our sponsor for the event, Chiesi, and also Asthma Australia, the Thoracic Society, and the Centre of Excellence in Treatable Traits for the collaborative work that's been going on in this area.